Okay, this next section of shoulder anatomy is going to be all about the muscles of the shoulder. So when we go about talking about the muscles of the shoulder, I try to look at them as two different groups. The first group is the muscles that are primarily acting on the scapula. These are going to be your big back muscles, the muscles that are responsible for fixing the scapula to the thoracic wall. They're going to be vital in terms of shoulder movement, but they're not actually causing the glenohumeral joint movement. They're actually stabilizing or moving the scapula. The other muscles that we'll talk about are the groups that actually act on the humerus at the glenohumeral joint. So one group is all the big scapular stabilizers and scapular movers. The other group is going to be all those acting on the humerus, causing the motion that way. Just looking at a picture from the back here, understanding the different layers of where the muscles are at. Your trap is the most superficial muscle in the upper back. We'll talk about it more in detail. This side doesn't have it, but it's the most, so when you cut off the skin, get through the fat and the fascia, the first muscle you're going to see is the trapezius. Underneath the trapezius, you're going to see the rhomboid major and minor, primarily responsible for shoulder retraction. You'll have your levator scap up here, and we'll talk about the latissimus dorsi, but really the lat is a big back muscle, but it doesn't actually touch the scapula. The scapula runs right here along the pointer, and the latissimus dorsi actually does not touch the scapula at all. So when we go through all these muscles, I want you to know origin, insertion, action, and innervation. I've talked about it in lab, how I don't want you to just memorize these slides, memorizing the actions and whatnot. I want you to figure them out. So start off by, do read the origin and the insertion, but actually understand what it means. Look at different pictures. Look at the pictures that I give you. Look at pictures from the internet, different study material. Look at these pictures and actually understand how these muscles run, how the fibers run, and if you know where they originate and where they insert, where they start and where they end, and how the fibers run, then you should be able to understand the action. Because a lot of muscles are going to have multiple actions. It really just depends on which way their fibers are running and which way they cross the joint. So the first one here is your trapezius. It's the big, if there's both of them together, you'll have a big diamond-shaped muscle in the superficial back. It has a very long, broad origin. It's going to start up on the occipital bone, spanning all the way down the cervical vertebrae, which is that nuchal ligament. Because in the cervical spine, because of the lordotic curve, it doesn't actually touch the spinous processes of each individual cervical vertebrae, but there's this very thick ligament called the nuchal ligament that it will attach to. And then once you get to the thoracic vertebrae, it will touch the spinous processes, or the part of the vertebrae that's sticking out backwards, through all of the thoracic vertebrae. So base of the skull, the occipital bone, the nuchal ligament along the cervical vertebrae, and all 12 spinous processes of the thoracic vertebrae. Then they're going to come around and they're going to insert on the distal clavicle, the acromion, and the spine of the scapula. So again, it's giving you that half of a diamond shape when you're just looking at one. Based on how this runs, you're going to have different lines of pull because these fibers are going to run in different ways. So if we understand that the upper fibers of the trap are going to be up here, what are they going to do to the scapula? They're going to end up elevating the scapula because of how they're positioned. You look at the middle fibers of the trapezius. When they contract, they're going to pull the scapula straight in, which is your scapular retraction. And then you're looking at the lower fibers, what's it going to do to the scapula? It will end up pulling it down. And then the upper and lower will help to rotate. So if the upper located this way, it's going to help with upward rotation. The lower are going to help with downward rotation. So understanding how the fibers run should be able to help you understand what the action actually is. When it comes to memorization, you just need to memorize each nerve. There is really no trick. This might be a good place for you to make index cards because you just have to memorize which nerve goes with which muscle. So in this case, the trapezius has the accessory nerve, or cranial nerve 11 is the nerve that innervates the trapezius. Here's a different picture. I really like this picture here. What we're looking at is a right shoulder. We're looking down at it. So the head's right here. This will be the top of the head. This is the top of the shoulder. So we have the clavicle, the acromion, and the spine of the scapula. So we're looking down from the top. And the trap is going to insert, like I said, on the distal clavicle, the acromion, and the spine of the scapula. So it's coming from the spine all the way over and inserting here. The interesting thing is, on the outside here, with the exact same location, but on the outside is where the deltoid is going to originate. So the deltoid originates on the distal clavicle, the acromion, and the spine of the scapula. So the insertion of the trapezius and the origin of the deltoid are going to have the same location, one on the inside though and one on the outside. And here's a closer look at what it looks like in terms of the line of pull. Here your upper fibers pulling up, your middle fibers pulling straight into retraction, your lower fibers are pulling downward. As I mentioned before, the latissimus dorsi does not actually affect the scapula. It is going to affect more of the humerus, but it is a very large back muscle, so we'll talk about it in this position. Again, not trying to memorize all these words of origin, but understanding where it runs. It is going to be on the spinous process of T7 to T12, all the lumbar vertebrae, and it's actually going to go down and touch the sacrum and cover the ilium, or the iliac crest as well. This stuff, this white looking stuff that we see, is tendon type material. We call it fascia, or oftentimes it's called aponeurosis. And aponeurosis is going to be a long or a flat, thin tendon-like structure versus having a nice round thick tendon. We'll have an aponeurosis, which is the flat kind of broad type of tendon. So the lat isn't going to have muscle fibers all the way up to each of those bones. It's going to have this very broad expansion, and that expansion is going to end up touching, again, T7, T12, lumbar vertebrae, down to the sacrum and around the iliac crest. The interesting thing is it has a very broad origin, but it's going to have a very specific insertion point. It is going to insert on the floor of the bicipital groove of the humerus. So it actually comes from the back into the armpit, around into the front side of the humerus, into the bicipital groove. Again, if you understand how it runs, then the action should make sense. When the arm is in flexion, it will extend it. When it's in abduction, it will cause adduction. And based on the location, it will also do internally or medial rotation of the humerus. Swimmers tend to have very developed latissimus dorsi, and that's because if you look at extension, adduction, internal rotation, that is the motions that you go through when you're swimming, especially with the freestyle stroke. When you are just swimming overhead, that's what you're doing: extension, adduction, and internal rotation. So it's also a big muscle that's used when you're pulling your body up, doing a pull-up. Here's a couple different pictures that I like, just because it's hard to sometimes picture where the lat is actually running. So again, it's a very large back muscle. Here's your aponeurosis here, and it's coming up, and you can't actually see the insertion point in this picture because there's other musculature on this person, but it is going to the front side of the humerus, the anterior side. Here's a picture of the back. Again, here's the lat without other musculature, your aponeurosis here, and it's coming around into the armpit, into the front of the humerus and the bicipital groove. And I really like this picture here because it shows you from the anterior side how the lat is on the posterior side, but the insertion is right here on the anterior side of the humerus on the bicipital groove. Your levator scapulae is not a very large muscle. It's not going to help all that much with stabilization, but it is going to cause a lot of movement of the scapula. This one is going to start up on the cervical spine, C1, 2, 3, and 4. So it's going to have slips that originate on C1, 2, 3, and 4. And then it's going to insert on the superior medial border of the scapula. I would say it's the superior angle of the scapula is where the levator scapulae would insert. Because of where it's at, you can again kind of tell what it's going to do. It's going to pull the scapula up, so it will cause scapular elevation, and it will also cause scapular downward rotation, because when it pulls, it's going to end up pulling this way, which is going to end up causing your scapula to downwardly rotate. So again, hopefully that kind of makes sense if you can see how the fibers run. The levator scapula is innervated by the dorsal scapular nerve. Then we have our rhomboids, rhomboid major and minor. There are two separate muscles. The major is obviously a lot larger. Your rhomboid minor is a lot smaller. Because the rhomboid minor is so small and it's right next to the rhomboid major, I just talk about the rhomboids together. I mean, do know that they are two different ones. Do know that the minor is superior to the major, is superior as in on top of. But they're going to start on your thoracic spinous process, your T2 to T5, and then they're going to run straight across and insert on the medial border of the scapula. Again, this one should be pretty obvious based on how the fibers are running. It is going to cause scapular retraction. The rhomboids are also really important in fixing the scapula to the thoracic wall. So they're going to be there for that scapular stabilization. Like the levator scapula, the dorsal scapular nerve also innervates the rhomboids. Then on the front side, we have our pectoralis major. Pectoralis major is going to have a very broad origin, so it's going to have some fibers up on the medial part of the clavicle, along the entire sternum, and actually have some on some of the rib cage. So you have a very broad fan type of origin, and like the lat, but on the front side, we have this very broad origin, but we have a very specific insertion point. The insertion is going to be on the lateral lip of the bicipital groove. So the lat is coming around, inserting on the bicipital groove. We also have the pectoralis major inserting on the bicipital groove. And again, hopefully we can figure out what this does. If our shoulder is out in abduction, it will cause adduction. It will also cause internal rotation, because that pulls is going to actually pull the humerus into internal rotation, and definitely does horizontal adduction. So again, hopefully those are kind of obvious. The pectoralis major is innervated by the medial and lateral pectoral nerve. Both of those are required for full innervation of this muscle. The pectoralis minor is going to be deep to the pectoralis major, so it's going to be sitting underneath it. It's going to have, it's going to start on the 3rd, 4th, and 5th ribs. So it's going to have 3 slips that start on the 3rd, 4th, and 5th, and then they're going to come together with one insertion on the coracoid process of the scapula. So if you remember, look through what this looks like, we have our clavicle here, the scapula is sitting in the back, here's your acromion coming around the front, and then you have the projection of the coracoid process coming out of the front. So the pectoralis minor is going to have an attachment on the coracoid process of the scapula. Not a very large muscle, but it is one that's often tight, and is definitely linked to forward shoulder posture, because what this does when it is tight and shortened, and when it does contract, it's going to actually pull the scapula forward, causing an anterior tilt of the scapula. The pectoralis minor is innervated by just the medial pectoral nerve, where the pectoralis major is innervated by the medial and lateral pectoral nerve. The serratus anterior is a major scapular stabilizer. It's going to have origins on ribs 1 through 8, so all the way up, all from the very top, all the way down to the 8th rib. We have different slips where the serratus anterior is going to originate. Then it's going to come down, and in this picture right here, this is the glenoid fossa, and they actually took the humerus off and they opened it up, so they're pulling the scapula off the body. So here's the outside of the scapula, the lateral border. The medial border is actually in here, and that is where the serratus anterior is going to insert. So it's going to come from these 8 slips, come together, form one insertion point along the medial border, but it's underneath, so it travels along the rib cage under the scapula and then inserts on the medial border. This primarily will cause scapular motion. It will help with protraction and depression, upward rotation, but most importantly, if you think about anything else with the serratus anterior, most importantly, it's going to anchor the medial border of the scapula to the thoracic wall. It is a major scapular stabilizer during activity. This one is innervated by the long thoracic nerve. So sometimes weakness of the serratus anterior can cause winging. Sometimes damage to the long thoracic nerve can cause weakness of the muscle because the nerve is actually messed up. Either one could result in winging of the scapula. Here's a couple different pictures of the serratus anterior just so you know what you're looking at. This picture over here to the left is similar to the one that we just saw, where here is your scapula, but it's basically been pulled off the body, so you can see that the medial border here is where the serratus anterior inserts. In this case, the scapula is in the correct position where the shoulder would be, and this red dotted line is going to be on the anterior side of the scapula, is going to be actually where the serratus anterior is going to insert. So now getting more to the muscles that actually move the humerus versus the big stabilizers. The first one is your bicep brachii. We're going to focus on how these muscles affect the shoulder. So although some of these muscles will actually cross the elbow, we're not really focusing on what the bicep brachii or the tricep do at the elbow. We're focusing on what they do at the shoulder. So we do have the bicep is going to have 2 heads to it. We're going to have a long head and we're going to have a short head. The long head is going to travel through the bicipital groove. This picture to the left is a little bit easier to see. Travel through the bicipital groove, and then it's going to actually insert on the superior, the supraglenoid tuberosity of the scapula. So we have our glenoid fossa. There's going to be a bump on the top of it. It's called the supraglenoid tuberosity, so just a bump on the top of the glenoid fossa. So it's got a long, skinny tendon going through the bicipital groove to the top of the glenoid fossa. Remember how I mentioned before that the long head of the bicep tendon not only inserts on the supraglenoid tuberosity, but also has fibers going into the glenoid labrum. So when we have a lot of pulling from the long head of the biceps tendon, we can actually pull the labrum off of the glenoid fossa. The short head just shoots straight up and inserts into the coracoid process. You need to start keeping track of what inserts on the coracoid process. This is the second thing now that either inserts or originates on the coracoid process. The first one was the pectoralis minor. This one is now the short head of the bicep tendon, inserts there as well. Together, these are going to come down and insert on the radial tuberosity on the radius. So they will affect the elbow because they do across the elbow joint, but again, we're not focusing on that right now. In the shoulder, the bicep brachii will primarily, again, it's positioned on the anterior side of the body, so it will help with shoulder flexion. If the shoulder is out in abduction, specifically the short head will help pull it in toward adduction. And the musculocutaneous nerve is the nerve that innervates the bicep brachii. Coracobrachialis is actually very similar to the bicep brachii. It's going to have the same line of pull. It's actually going to have the same origin. The coracobrachialis is going to start on the coracoid process. Again, that's the third thing now. So we have our pectoralis minor on the coracoid process. We have the short head of the biceps tendon, and we have the coracobrachialis are all going to have origin or insertion on the coracoid process. It is not going to cross the elbow joint, so it's going to start on the coracoid process, shoot straight down, and insert on the anterior medialish part of the humerus. So it's a relatively short muscle, but will have the same line of pull as the bicep brachii. It's also innervated by the musculocutaneous nerve, which is the same one that innervates the bicep brachii. It's also going to have the same action as the bicep brachii, with shoulder flexion and shoulder adduction. I mentioned the deltoid origin already, how it's the same as the trap, but on the outside versus the inside. So here's the posterior side in this picture, here's the anterior side, so the spine of the scapula, the acromion process, and the clavicle. That's for the trap is going to be this muscle up here. The deltoid is the one down here. So the deltoid is going to touch the spine of the scapula, the acromion, and the clavicle. This is a picture of just the posterior part, not the anterior part. Because it does cap the shoulder, it has posterior fibers, it has lateral fibers, and it has anterior fibers. It is going to have different types of actions. It is going to all come together and insert at one specific location on the lateral part of the humerus, about mid humerus is the deltoid tuberosity, is where all of these fibers are going to insert. So based on the line of pull, though, you can see that our anterior fibers in the front here, they're going to help shoulder flexion and shoulder internal rotation. The middle fibers, when they contract, it's going to pull the shoulder straight out into abduction, and the posterior fibers are going to pull you into extension and external rotation. So hopefully, again, you understand that how the line of fiber thing actually works. And the deltoid is going to be innervated by the axillary nerve. The tricep brachii is going to have 3 heads. That's why it's the tricep. We're going to only really focus on one right now because only one of those heads actually cross the shoulder joint. So only one of the 3 heads of the tricep actually affect the shoulder. The other ones are going to affect just the elbow. So in this picture right here, it is covered up the origin, but the long head of the tricep is going to cross the shoulder joint, and it's going to originate on the infraglenoid tuberosity of the scapula. So, like the long head of the bicep originated on the supraglenoid tuberosity of the scapula, above the glenoid fossa, the long head of the tricep is going to insert on the infraglenoid tuberosity of the scapula, which is a bump on the inferior part of the glenoid fossa. And then along with the lateral head, which is out here, and the medial head, which is deep to this, they're all going to insert collectively on the olecranon process of the elbow. Again, we're not too concerned about that right now. Obviously, because we're on the posterior side here, when we talk about what actions does the tricep do to the shoulder, it's on the posterior side, it is going to do extension. If the shoulder is out in abduction, it will help bring it back in with adduction. And it is innervated by the radial nerve. Here's a different picture of how the tricep, the long head of the tricep here, is the one that originates on the infraglenoid tuberosity, where the other heads do not touch the shoulder. All right, so then we get into the musculature of the shoulder. It is a really important concept to understand dynamic stability versus static stability. In the shoulder, we've already talked about it in the last lecture, how we give up a lot of stability. We have a lot, there's not great bone-on-bone stability. There's not a lot of very strong ligaments. We have our joint capsule, and there's some thickenings in the joint capsule. The labrum is not very big and strong. Everything we talked about really led up to the fact that statically, the shoulder is not very strong. We just don't have the proper inert tissues, the size of the capsule, the size of the ligaments, the amount of bone-on-bone contact. All that really just leads to poor static stability. Static stability is all those structures that are there that are not able to contract. They are, as long as they're going to work. Unless the force is too high, then they'll rupture. They're not able to perceive what's going on. They can't contract. They're not able to try any harder. They're one length, and they'll do their job until the job is too much for them. On the other hand, dynamic stabilizers, which in this case is going to be our muscles. Muscles are responsible for kind of reading the situation and figuring out how much work needs to be done. There's a lot of proprioceptors in the shoulder, and because we have such poor static stability in our connective tissue, we have to have a lot of good dynamic stability. In dynamic, that's the movement idea. So dynamic is going to be the muscles. Muscles are able to contract, they're able to relax, they can go harder, they can go a little bit easier, they're able to perceive what's going on and prevent injury through the specialized proprioceptors, all those things. So because we have such poor static stability, we have to rely on dynamic stability. So specifically, the dynamic stabilizers in the shoulder are going to be your rotator cuff. There are 4 different rotator cuff muscles that are going to surround the entire shoulder and act as our dynamic stabilization. We'll talk about each of these 4 muscles individually. Each one is going to have a specific job. We will talk about what actions they do perform, but in reality, we're talking more about their role as the dynamic stabilizers versus their roles as internal or external rotators. Our 4 muscles are going to be the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. So looking at the rotator cuff from a couple different angles, here is, down here to the bottom left here, is a look at the anterior part of the scapula. Here's the anterior humerus, here's the anterior scapula, here's the coracoid process, your acromion process. On the entire your entire subscapular fossa, so if you remember your anatomy from the scapula, you have the subscapular fossa on the anterior side. In that subscapular fossa is going to sit the subscapularis muscle. It's going to originate all the way on the inside. It's going to insert on the lesser tuberosity of the humerus. Then on the back side, we have the spine of the scapula that splits the top and the bottom. In the top, we have our supraspinous fossa, and our supraspinatus muscle is going to sit in the supraspinous fossa. Then we have our infraspinous fossa, the location below the spine of the scapula, where the infraspinatus muscle is going to sit. Both of those are going to come out and insert on the greater tuberosity. Then underneath that, we have the teres minor, which is just going to originate on the side of the scapula, the lateral border, and is going to go underneath. So relatively tiny muscle in comparison to the other ones. And then looking from a superior view, we have our supraspinous fossa up here, so our supraspinatus, and then our infraspinatus and our subscapularis, and we can really see just a tiny piece of the teres minor. But the big idea here is that these each are going to have their own action, but their primary job is to act as dynamic stabilizers for the shoulder to help prevent injury. Again, just a different view, a different picture for you to look at. So individually here, the first one is the subscapularis. Like I said, it's going to originate in the subscapular fossa on the anterior part of the scapula, and it's going to insert on the lesser tubercle. It is going to be responsible for humeral head internal rotation, so it will pull it inward, But more importantly, again, humeral head stabilization. It's his job to keep the humeral head in place. The subscap is innervated by the upper and lower subscapular nerve. Then we have our supra and infraspinatus. Like again, I mentioned these. Supraspinatus is your supraspinous fossa out to the greater tuberosity. Here's your infraspinatus, and your infraspinous fossa out to the greater tuberosity. Your supraspinatus will help with abduction of the shoulder, bringing your shoulder out because of the location. When it pulls, it will pull into abduction. Your infraspinatus will help with shoulder external rotation. Some horizontal abduction, so pulling your arm out and around. But again, more importantly, their jobs are to stabilize the humeral head. Both of these are innervated by the suprascapular nerve. And then the top one here, your teres minor. We do have a teres minor and a teres major. The teres major is not part of the rotator cuff. It's going to be a separate muscle. So the fourth rotator cuff muscle is a teres minor. It's going to start on the lateral border of the scapula, and it's going to insert on the greater tuberosity as well. It will help with, like the infraspinatus, it will help with external rotation, but importantly, humeral head stabilization. It is also the axillary nerve. And if you remember that the axillary nerve also innervates the deltoid muscle. Then, like I said, not a rotator cuff muscle. The teres major is going to originate on the inferior angle of the scapula, and it's going to basically follow. It's going to be considered a mini latissimus dorsi. The lat, remember, it started on the back. It didn't touch the scapula, but it came around the armpit and inserted into the bicipital groove. The teres major is a much smaller muscle, but it's going to have the same pathway. It's going to start on the inferior angle of the scapula, then it's going to go around to the front side of the humerus. It's going to actually insert on the medial lip of the bicipital groove. So on the front side of the shoulder, in the bicipital groove, we have our pectoralis major, we have our latissimus dorsi, and we have our teres major. All are going to be inserting in the same location. If you do consider it a mini lat, then it's going to have the same actions. So the lat and the teres major both do extension, internal rotation, and adduction. And it's innervated by the lower subscapular nerve. I like this picture because it shows you the specific locations of origin and insertion. Red is going to be origin, blue is insertion. I really like it because of especially right here where I talked about the three muscles that are located in order on the anterior part of the humerus. So here is the location for your pectoralis major, here is your latissimus dorsi, and here is your teres major, are all going to be inserting all in a row on the anterior side of the humerus at the bicipital groove. And you can just look at the other ones for references. Okay, so that's the end of the muscles. Just a couple other things that we have here. The first one is the scapulothoracic or scapulohumeral rhythm. The glenohumeral joint itself, the actual ball and socket, what we consider sometimes the shoulder, really it has a limited amount of motion. If our scapula did not move at all, then we would not have really more than about 60 degrees of shoulder flexion or shoulder abduction. We would definitely not be able to get overhead if our scapula was not able to move. But we are able to get over our head. Normal is about 180 degrees of total motion, whether that's flexion or abduction. And we have that because both the glenohumeral joint are moving and the scapula is moving. In order for the scapula to move, we have to have the AC joint and the SC joint move. So all four of the joints are all moving together in order for us to get the full 180 degrees of motion. Now, how much the scapula moves and when it moves is pretty predictable. So we call that the scapulothoracic or scapulohumeral rhythm. So it's the ratio between how much movement is occurring in the glenohumeral joint between how much movement is occurring in scapular upward rotation. So basically this is saying the humerus is going to move about twice as much as the scapula. So if we think about this, if it's going to be twice as much, then about 120 degrees of glenohumeral movement and then about 60 degrees of scapular upward rotation is going to give us our full elevation. But it's kind of broken up into, we don't have all 120 degrees of glenohumeral motion and then all 60 degrees of scapular rotation. It's kind of mixed up. So if we're going from a resting position very early on in the motion, it's going to be all glenohumeral joint movement. So between about 0 and 45 to 60 degrees, it's pretty much all glenohumeral. And then in the middle part of the motion, when we're going to shoulder, say shoulder abduction, it's a 1-to-1 ratio. So for every degree the glenohumeral joint moves upward, we also have 1 degree of scapular upward rotation. So that's where it's a 1-to-1 ratio. And then we're going to end up running out of the ability to the scapula to rotate any further, so then we're going to be left with all glenohumeral movement. So in order for us to get full range, we start off, and we can actually look at someone's back, and as they go slowly into shoulder abduction, you'll see that their scapula really do not move at first, and then in that mid-range portion, as their humerus moves up, so does their scapula, and then at the very end, their scapula stops moving, and it's all glenohumeral. And that's what we're looking for. We want them to be the same on both sides. We want to see a normal, nice rhythm, and have the scapula move upward, and have that move upward at about the mid-range. And you can look at these 2 videos on YouTube to see what that actually looks like. Okay, so then the next part is going to be about the nerves. We're going to be pretty concerned with nerves when it comes to the shoulder because we see a lot of neck problems that end up resulting in looking like shoulder pathologies. And we'll also get a lot of pain in the upper extremity as a result of neck pathologies. So a quick review here, hopefully you guys don't know this, but here's our spine. We have 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, and then our sacrum and coccyx. So that's what the spine looks like. Then we have spinal nerve roots coming out of each pair of vertebrae. So whenever 2 vertebrae come together, we're going to have a spinal nerve root come out. And the spinal nerve root is what's going to feed the entire body peripherally. We're going to focus on, again, like I said, the brachial plexus. The brachial plexus specifically is C5, 6, 7, and 8. And the spinal nerve roots are named for which vertebrae they come out. But the cool thing about this is that we actually have the brachial plexus, which really means they all mix together. They're going to plexus together, and they're going to create new nerves. This is actually a positive thing because say we have damage to C6 all the way up here at the spinal vertebrae. Because C6 doesn't just go to one muscle, it actually combines with other ones. If C6 is damaged, we will still have function in that muscle because other nerves are also feeding it. So it's kind of a protective mechanism. Kind of a fun fact here, in the cervical spine, we have the nerve come out the top. So this is our C1 vertebrae. The C1 nerve root is going to be coming out the top, C2, C2 up there. Then we get down to T1 and we start coming underneath. What this means is there are actually 8 cervical nerve roots, but only 7 cervical vertebrae. So we get an extra one in the cervical spine. So even though there is a nerve called C8, there is not actually a C8 vertebrae. Okay, so the actual makeup here of these actual nerves, they're going to be combined sensory and sensory and motor. So back here is the dorsal root or the posterior root. These are going to be all sensory fibers. They're going to be looking, in this picture, they're going to be blue. So dorsal is posterior, and that's sensory. Then we have ventral, that's anterior, and that's motor. So here's your spinal cord. Here's your spinal nerve root. This is what we're actually talking about here. At first, all of the dorsal stuff is all sensory. All of the ventral is all motor. But then they're going to join together and they're going to actually mix. So your spinal nerve root is actually mixed sensory and motor. And then they're going to start to break off. And we're going to have these ramus or rami. Our posterior or dorsal rami are going to see they have a red line and a blue line. Now they're mixed. They can carry both sensory and motor information. These dorsal rami are going to go to the facet joints, skin, and deep muscles of the back. So we're not going to really focus that much on the dorsal rami, But the anterior or ventral rami, or ramus, are the ones that are going to be sensory and motor, and these are going to go to your upper and lower extremities and your primary trunk. So what we're going to be looking at in terms of nerves and nerve problems are going to be all about the ventral ramus. And that just says all of that. I'm not going to go into the brachial plexus in this lecture because we're going to end up doing it in lab, but you will have to draw the entire brachial plexus, so make sure that you use this PowerPoint as a reference. But I will say that as the brachial plexus, the nerves come out of the neck, they actually travel laterally from the neck. They go under the clavicle, but over the first rib, and then continue into the axilla, which is the armpit. And then they're going to have different divisions and branches and things like that. And we'll learn how to draw all this. What I also wanted to point out in this PowerPoint is that these nerves in yellow should look familiar, sound familiar, because these are all nerves that come off of the brachial plexus, and these are nerves that I'm making you, they're going to innervate the muscles of the upper extremity. So we know the dorsal scapular nerve. We've seen all these nerves before because these are the nerves that are going to innervate different muscles. Lateral medial pectoral is your pectoralis major. Suprascapular, supraspinatus. Dorsal scapular is your rhomboid and your levator scap. So they're going to end up matching all of these up. But we will talk about that more in lab.